Recording is on, no? Recording
Yes, sir.
on? Okay.
Yes.
Now, what did we discuss last class? Did we discuss etiology?
Yes, sir.
Huh?
No, sir.
No, sir.
Did we discuss this?
We have stopped here, sir. This slide.
Stop here.
I've stopped at this slide.
Yes, sir.
Okay, good. Thank you. See, etiology, you need to know very clearly, very well about the challenges involved in the peptic ulcer. How peptic ulcer, etiology means what is the origin of peptic ulcer? How will one get peptic ulcer? Okay, you must really know this. Very important. How will one get peptic ulcer? Okay, so as I told you earlier, H. pylori is one of the notorious microorganisms that is responsible to cause peptic ulcer. Okay, but there are many ways of the entry of H. pylori, and we'll discuss that later on. Then lot of drugs that will induce peptic ulceration. Tell me one drug that will cause peptic ulceration.
NSAIDs, aspirin.
That is many antibiotics. In fact, now the giving the PP2 PPI is become very common in the hospital. Tons and tons of PPIs are given. Okay, so because in order to counter the effect of the drugs, many drugs that are responsible for causing the peptic ulceration. So we need to be very careful. Most and all those things is the 1 minute. I'll just have some water and come. Okay, drugs, lifestyle factors. Tell me the lifestyle factor that will cause ulceration. Is a common sense. Tell me lifestyle factors. Any of you have become any of you have become ulcerative because of lifestyle changes? Tell me what lifestyle.
Yes.
Tell me what
Yes, sir.
lifestyle ulcers.
Food style, sir. Food.
Eating food.
Eating more spicy food.
Eating more spicy food. See, for an Andhra guy, if you want him to eat a less spicy food, he will rather stay hungry than eating, isn't it?
Yes, sir.
Yes, sir.
Same goes for Rajasthanis also, sir.
Huh?
Same goes for Rajasthani also, sir.
I
Smoking
know, we are a
also, sir.
multicultural people here. Okay, so lifestyle, rather than eating breakfast at 8 o'clock, eat breakfast at 11 o'clock. Rather than eating dinner at 7 o'clock, eat dinner at night 12 o'clock. Isn't it lifestyle?
Yes, sir.
Yes, sir.
Sir.
So drink more of this Pepsi in style. Okay, it is definitely, see, Pepsi and Coke, they are the one which kills your stomach left, right, and center, because it is an aerated drink, isn't it? When you drink aerated drink, it is aeration with what? What is aerated in that?
Carbon dioxide.
Carbon
Carbon
dioxide.
dioxide. So what is the pH of your stomach?
1 to
1.5 to
So
3.5.
when carbon dioxide goes to a high pH environment, what happens? Tell me, when carbon dioxide goes to the environment of high pH, what happens?
Increases the more.
Huh?
Stomach is low pH, right?
pH decreases, isn't pH becomes, pH increases rather.
Increases.
It becomes
Neutralized.
less acidic, isn't it? So the pH is made one so as to support the environment of the stomach and to make sure that things happen normally over there. But you in style, Every day with a morning breakfast, afternoon lunch, tea, whatever it is, you say, I don't take tea. I'm a new generation fellow. I want only Pepsi Coke. And then that means you're doing things to destroy your stomach. You understand what I'm saying? Okay. So you need to see science behind everything. Lifestyle changes. Severe stresses. Tell me, have you ever undergone this? Anybody?
Yes, sir. During exams.
During examination time, any challenges at home, any challenges in your hostel, any challenges in your friend circle, then person goes into deep depression. These days, depression has become a common word and goes into deep issues and gets into psychological stress. That leads to all acidity. So get into one pantoprazole and any of those things. Okay. Then there are all the diseases are there. Hypersecretory diseases. Okay. Hypersecretory status, which are uncommon. So, and then there are many genetic factors are there. People, this is generally carried away by genes. Okay. So when we look at these etiological factors, most of these reason for ulcer is outside or inside. What I meant to say is external or internal. Internal is always manageable. So that is why what we say is take care, don't abuse your stomach. If you abuse your stomach will start misbehaving. Then you will suffer lifelong. Okay. Okay. So let's look at the first one, H. pylori infection. H. pylori infection, and NSAID use account for most of the peptic ulcer diseases around now. Okay. So the rate of H. pylori infection for duodenal ulcers in United States is less than 75% of the patient who do not use NSAIDs. So one need to be very careful when you use NSAIDs. Excluding the patients who use NSAIDs, 61% of duodenal ulcers and 63% gastric ulcers were positive for H. pylori in one study. So what I'm trying to say is that these two are brothers, NSAIDs and H. pylori. So once you don't know, you take for every small thing, swallow a paracetamol, swallow a aspirin, swallow especially aspirin and that what is that? Name me one more this painkiller.
Ibuprofen.
Ibuprofen is one of the worst drug ever available in the world. It is more stronger ulcerative than that of paracetamol, than that of aspirin. Paracetamol is a more safer drug as far as the GI is concerned. Ibuprofen is a worst, it is just worst irritator of the GI. So as far as possible, that's why, listen, I'm a pharmacologist. I tell people, don't take medicines. Don't indulge yourself with medicines. For every small thing, don't take medicines. Medicines, okay, it will reduce your headache when you take NSAID, but look at the damage that it does to your stomach. Okay, ibuprofen, look at the damage that it does to your stomach. And then once an entry has happened, then H. pylori will come over there. It will come and happily sit over there. You don't know H. pylori. H. pylori wouldn't have been there. But infection, this ulceration has started now with NSAIDs. So prevalence of H. pylori infection in complicated ulcers like bleeding and perforation is significantly lower than found in uncomplicated ulcers. What I'm trying to say is that H. pylori is there as an initiator. Okay. And then it will cause complications. And then when you look at H. pylori, no, I was there. I'm not now. I did my damage and ran away from the place. Okay. Then this bleeding perforations happen. Other day I explained to you. Go on scratching like this inside. Go on causing a wound. Deep bleeding has started. Perforations, the stomach has all holes there. And then there are a lot of complications developed. Then H. pylori will not be there. So you have to manage it differently, more complications. Okay. Need to be very, very careful. So that is why we say stitch in time saves 9. Next, I'll just briefly discuss with you about drugs. NSAID is the most common peptic ulcer causing disease drug. Okay, and drugs, these drugs disrupt the mucosal and permeability barriers, render the mucosa vulnerable to injury. As I told you, these drugs are acidic moieties. These acidic moieties go sit on the membrane, that is mucosal membrane, and start irritating there. And as they start irritating, it will cause some kind of a scratch kind of a situation over there. Then it will worsen. Well, 1 or 2 days, nothing will happen. 1 or 2 doses, regular dose, nothing will happen. All these are possible only when one takes this on a long period of time. Almost as many as 30% of adults taking NSAIDs have GI adverse effect. Remember, not 100%. 30% of the adults taking NSAIDs have GI adverse effects. Okay, and the factors associated with an increased risk of duodenal ulcers in the setting of NSAID include history of previous ulcer diseases. Okay, so if at all he had some this, then this will add to the wound. This add to the injury, and then wound will increase. If it is older age, with the older age, a drug will stay. The GI motility would have been decreased, and so this will cause a grain. And listen here, the sex difference also is there. Females are more vulnerable to the NSAID ulcerative properties than the male. And high dose, always restrict oneself to the prescribed dose. When because of too much of a headache, so much of a headache, take not one tablet, 2 tablets. 2 tablets is not working, 3 tablets, you are in for a danger. High dose of NSAIDs. And daily you take 2 to 3 NSAIDs. Very, very danger. Okay. And along with that, one uses anticoagulants and many other severe comorbidities. So one, it will be safe. Then add to this, add to that. So you've been studying about drug-drug interaction, drug-disease interaction. Very, very important. So with one, nothing much will happen. With multiple, things will go wrong. Okay, so one, you need to be very, very careful and avoid as much as possible. Tell me one of the anticoagulant which is commonly used.
Heparin.
Yeah, heparin. Do they use it commonly? Okay, anyhow, let me not go over there. See, aspirins are used as a blood thinning agent, isn't it? Antiplatelet agents. And it is generally used as an antiplatelet over a long period of time for elderly patients. And we'll look into that later on. So a long-term prospective study found that patients with arthritis, older patients who regularly take low-dose aspirin were at high risk for dyspepsia, severe enough to necessitate discontinuation of this NSAIDs. So generally patients with arthritis, leave aside arthritis, the patients with some kind of cardiovascular diseases. Tell me what is a low dose, what is that, what aspirin, low dose aspirin means, what is the dose of aspirin? What is a dose of the antiplatelet dose of aspirin? Quick, common sense. Huh?
160 to 320.
Who is that telling that? Let me see. Who is that? Who is that 160 to 320? Who said that?
Me, sir.
Betsy. God, Betsy, you should be demoted to second year now. See, second year is where you studied all this cardiovascular disease, isn't it? Haven't you studied about low dose aspirin, 75 and 150 mg? 75 aspirin is a baby aspirin, we call it. 75 aspirin is a blood thinning agent. Is a platelet, antiplatelet drug. Okay. So invariably for every senior citizen, in fact, it is made mandatory also, senior citizen, they give low dose baby aspirin, low dose aspirin, which is 75 mg aspirin, but later on they may go up to 150, maximum dose is 150 mg. What is the role of this aspirin? They will inhibit the platelet aggregation and make blood more thinner. And so coagulation will not happen. As a result, see, even if the patient having some kind of a arthritis or some kind of the cardiovascular disease, like even this cholesterol accumulation, or some kind of whatever is it, which leads to which, so the blood will be thinner, flow smoother in spite of constriction of the vessels. Okay, in spite of atherosclerosis, in spite of any kind of a sclerosis in the vessel, the blood will move faster. Okay, so you, as you go to, that's why I've been telling you, you must look at the doses, you must look at the 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 treatment that is given. Most of the patient's treatment, you have to screen out why, what is given. Forget about theories. You are Pharm D students. Pharm D students are more practical students, not like a B Pharm where we are more theoretical students. So you have to know what is given for what, why, when, where, what. Okay, chalo. So low dose aspirins were at an increased risk of dyspepsia, and so they may even reach to lowering discontinuing NSAID. But if you discontinue NSAIDs, then they have a risk of sclerosis. Many people will come to many kind of sclerotic disorders. They come into the hospital. Many kind of vascular disorders, they come to the hospital because of not taking aspirin also. Okay, so that is why better management NSAIDs should be discussed with older patients in order to reduce NSAID associated GI event. Who does these things? It is not the doctor. That is why Pharm D is introduced. Pharm D people should be knowing all possible challenges. Otherwise, you are not necessary in the profession. You should be knowing all possible challenges, should be accessible to the patient, explain them what is the problem of this, because for them, they take NSAIDs routinely. Okay, chalo. So, one moment. Just give me a minute, I'll come back. Okay, sorry, there was a urgent call from my office. Okay, where am I? So, who does this thing? It is the Pharm D people, clinical pharmacist. You should be like, in Baptist, you are called as a drug experts. And so when Betsy said, no, this is given for 350. I'm not naming you, okay? Just don't misunderstand when I say your name. But it is it is very ridiculous. You should never use common things like this. You should be knowing it, okay? Learn this thing. That is why I keep on insisting you are the drug expert. You have to make efforts to know all aspects of the drug. Okay. In fact, there is a retrospective study in UK shows that the low dose of aspirin prevention of cardiovascular disease identified risk factors for uncomplicated peptic ulcer disease. And so, as I told you, this is generally given for prevention of cardiovascular events. And just give me a minute, okay? Ma'am, good morning. Hey guys, sorry, some calls we cannot cut the calls. These are all busy, important calls.
Yeah, it's
Okay.
okay. Sir.
Okay. What I was telling you is that the people with previous history of peptic ulcer disease, people who are using NSAIDs or oral steroid and agents or acid suppressive agents, especially this problem is with tobacco smokers. Okay, remember. This is also important call. Okay. Sir, good morning. Really, ಇವತ್ತು ನಂದು ಬಂದಿಲ್ಲ. One moment, please. Okay, okay. So the anemia, as it's smoking, tobacco is one of the worst cause for this. Must be careful. Stress, depression, anemia, and then many other emotional disorders like social deprivation. All these things will make one more vulnerable. Okay, so although the idea was initially controversial, but now it is very clear that H. pylori and NSAIDs are both to work together initiating the peptic ulceration. They are all function synergetically. In fact, in one of the meta-analysis, that means one of the review of lots of literatures shows that H. pylori eradication in NSAID cases before is associated with a decrease in the peptic ulceration. So it is very clear, although the prevalence of NSAID gastropathy in children is unknown, but it seems to be increasing, especially in children with chronic arthritis treated with NSAIDs. So whatever it is, wherever there is children are treated with, people are treated with NSAIDs, may not be immediately, but over a short period of time, you will see. As I told you, children with ibuprofen, low dose of ibuprofen also, they have gastric ulceration. Along with that, corticosteroids do not increase corticosteroids alone do not increase the risk of peptic ulceration, but steroids with NSAIDs, there is a risk of gastric ulceration. So risk of GI tract bleeding may be increased in ulcers, of diuretics. So what I'm trying to say here is that it is a drug-drug interaction, or it is a additive effect. It is not just one drug, and alone may be safer, but 2 or 3 drugs having a similar problem will potentiate the problem. Okay, so one need to be very, very cautious, aware of these things. Okay, so you as a clinical pharmacist, it should be at the tip of your tongue. What will induce, what will not induce. So when you go out onto the wards, or when you go talk to the patients or patient dependents and all those people, or when you go for home medication review, it should be the tip of your tongue. Moment you see it, you should say, this is how it is, do this. See, lifestyle factors. There are lots of evidences that tobacco use is a risk of duodenal ulcers. Though it is not conclusive, but definitely there are evidences. So the support for a pathological role of smoking comes from finding that smoking may accelerate the GI emptying and decrease the pancreatic bicarbonate production. So sometimes people ask, what are the scientific evidences for what you're trying to say? It is definitely may not be, see, one should not become a victim so as to understand what happens. So there are a lot of studies which, though they show contradictory evidences, but one need to be very clearly understandable that smoking is one of the important risk factors. And smoking in the setting of pyloric, see, H. pylori, smoking alone may not be initially possible. Smoking with H. pylori or in H. pylori infection increases the risk of relapse of peptic ulcers. So smoking is harmful to the gastroduodenal mucosa, and H. pylori infiltration is denser in gastric antrum of the smoker. So that is how it may not be alone, but how does the H. pylori come in? H. pylori, remember, is an opportunistic organism, and when it finds a convenient opportunity in the stomach, it will just come in. Okay, so another thing, lifestyle. Ethanol. Ethanol is known to cause gastric mucosal irritation and non-specific gastritis because it is a foreign substance, alcohol. It will go and cause irritation to the gastric mucosa. Generally, a small quantity of alcohol may not, but alcohol added with the smoking will aggravate the whole situations. So there are evidences that consumption of alcohol is a risk factor for duodenal ulcers, and also they have found that duodenal ulcers are possibility when alcohol and smoking is given together. Okay, so when there are clear evidences are there, one need to take lots of care that they do not become victims of this. I told you about stress. Stressful conditions that may cause peptic ulcer disease includes burns, the central nervous system trauma, surgery, severe medical illnesses. Some people don't know what to do when they have so much of medical problem. Then that leads to stress, leads to anxiety, leads to ulceration problem. Serious systemic illnesses, sepsis, hypertension, respiratory failures, and multiple traumatic injuries increase the risk of secondary ulceration or stressful ulceration. So remember, when a person is stressed, he need to be always, when a person is going through injury or hurt or the sickness, need to be always optimistic and positive, because negative mindset will bring in the disease. Okay, so crushing ulcers are associated with brain tumors, or injury or Cushing ulcers are associated with brain tumors or injury, are typically single or deep ulcers that are prone to perforations. They are associated with high gastric acid output and located in duodenum or stomach. Extensive burns are associated with the curling ulcers. So these are all are stress factors. So stress ulceration and GI hemorrhages are complications, and that are generally seen in the ICUs. So severe illnesses and decreased GI are related to increased risk of GI gastric ulcerations and hemorrhages. Okay, so one need to be very, very cautious and see, in all the patients, you should tell them whatever is a problem, there is a solution. The doctors are at work on you. So don't complicate your disease by worrying. Don't complicate your disease by negative thinking. And you as a clinical pharmacist, as you do your counseling, you have to induce a positive energy in people. Okay. Now I'm talking about hypersecretory diseases. There are many diseases like gastroma, that is Zollinger-Ellison syndrome, or multiple endocrinal neoplasia, or antral G cell hyperplasia, or systemic mastocytosis, or basophilic leukemia, or cystic fibrosis, or low bowel syndrome, or hyperthyroidism. See, this hyperthyroidism is a very common syndrome these days. And some of these hypersecretory syndromes will lead to ulceration. Okay, one need to be very cautious about these things. So what we're discussing about all the etiological factors. Now, having discussed these things, let's come to some physiological factors. Okay, physiological factors. So they say in one third of the patients with duodenal ulcers, basal acid output and maximal acid outputs are increased. Okay, basal acid outputs and maximal acid outputs are increased. In fact, they have found in one study that yes. So in the individuals are especially high risk are those with basal acid output greater than 15 milliequivalents per hour. So increased basal acid output may reflect the fact that in a significant proportion of patients with duodenal ulcers, okay, and the parietal cell masses is also increased to nearly twice that of the reference range. So these are the cells where there will be histamine secretion will happen, and that will further facilitate the acid secretion. So it's all one-on-one complicated issues. Okay. So in addition to increased gastric and duodenal activity observed in some of the patients with duodenal ulcers, accelerated gastric emptying is often also present. Okay. That further leads to these complications. So this acceleration to a high acid load delivered to the first part of the duodenum, where 95% of the duodenal ulcers are located. And as a result, there is further complications. Now, acidification of the duodenum leads to gastric metaplasia. What is the pH of the duodenum? What is the pH of the duodenum? Is duodenum acidic? Hello, are you all there or no? Is duodenum acidic or alkaline? You're there or no? Ramya, is duodenum acidic or alkaline? Hello?
Yes, sir.
Yes,
Was I disconnected all this time? Was it disconnected all this time?
yes, sir.
Didn't hear your voice, sir.
Huh? Couldn't hear my voice?
No, sir.
Why did you not message me or call me? Gosh,
Only now, sir.
Just now, sir.
Just now.
this is that means I was talking all this time thinking that you're listening to me. Now,
No,
no.
sir, when you started asking questions at that time, it went off, sir.
Oh, is it? Oh,
Yes, sir.
you should be aware. Okay, okay. Were you here on this slide, physiological factors?
Yes, sir.
Yes, sir.
Yes,
Yes,
sir.
sir.
Yes, sir.
See, I am not seeing you physically, okay? I'm seeing you virtually, and virtual will give heart. So you have to keep me updated whether you are there or not there. Good, I
Yes,
asked
sir.
you a few questions. Well, what was I asking you?
pH of the intestine.
pH of duodenum.
Duodenum.
Yes. Who is that who told me pH of duodenum? I was asking you pH of duodenum. Is that Ramya?
Yes, sir.
Okay, Ramya, you tell me.
6, sir.
It is alkaline. Let us say that. Okay. So when the alkaline becomes acidic, then ulceration will be precipitated. When the acid become alkaline, when you drink some alkaline fluid, that will cause a manipulation. Okay. Okay. Now we must be talking together. Okay. So there are also seasonal changes or climatic extremes that may affect gastric mucosa and cause damage to the gastric mucosa and barrier functions, especially when you get into very cold. Any Delhiites are here?
No one, sir.
No one Delhiite. Okay. So you might in north reach a temperature which is 1 or less than 1. And then you will get into 40 degrees. And that kind of extreme temperatures, you will be having a risk of ulceration. Extreme cold, they have found out that the lower expression of heat shock proteins as well as decreased mucosal thickness in the gastric antrum of the patients with peptic ulceration who were on high risk of bleeding compared to those with a lower risk. So extreme climate, especially if it goes to minus 20, minus 30, very bad. That is why their lifestyle will be a little different. Okay. So the extreme hot, extreme cold, they have found it to be associated with low levels of occludin, HSP70, nitric oxide synthase, and epidermal growth factor receptors. But there is no statistical difference. But there is definitely an evidence found that extreme temperature may be one of the physiological factors for precipitation of the ulceration. In fact, okay, so these are some of them. Let us get into the last aspect called as genetic aspect. More than 20% of patients who have a family history of duodenal ulcers compared to only 5 to 10% of the control group. So in addition, weak association, they have been observed, they have observed the differences in the duodenal ulcers and the O type blood. So the patients who do not secrete ABO antigen in their saliva and gastric juices are known to be at a higher risk. So reason for this is basically gastric associations. Okay, the genetic association. So invariably, somewhere or other, genes play an important role, and a rare genetic association exists between the familial hyperpepsinogenemia, tenemic type 1, and duodenal ulcers. So how do one know? Most of the studies have shown these things. Okay, the peptic, so the H. pylori can also increase pepsin secretions, and a retrospective study has shown that there is a connection between H. pylori and the genetic connections. Okay, so genetic also plays an important role. So apart from all these things, there are many etiological factors, the disease factors like hepatic cirrhosis. How does hepatic cirrhosis comes? Remember, hepatic cirrhosis will be precipitated by alcoholism. So all complicated chronic obstructive pulmonary disease, COPD, also leads to the peptic ulceration. Allergic gastritis, eosinophilic gastritis also leads to peptic ulceration. Graft versus host disease leads to peptic ulceration. Uremic gastropathy leads to peptic ulceration. Then corrosive gastropathy, then bile gastropathy, all these have a possibility of precipitation of this. Then apart from that, autoimmune diseases, Crohn's diseases, then the many other infections I have listed over here, and many chemotherapeutic drugs like 5-fluorouracil, methotrexate, cyclophosphamide. These are all used as anti-cancer drugs. Then see, you going for local radiations, the X-rays or any of the UV radiations will lead to mucosal damage. That may lead to the development of duodenal ulcers. And the use of crack cocaine, localized vasoconstrictor, they may also lead to mucosal damage and the hypersecretion. So what I'm trying to say here is that there are lot of conditions, lot of epidemiological issues, lot of etiological issues. One need to be very cautious. That's why we call it as a lifestyle management, and you people should be experts in these things. Read more on these things. May not be for your examination, but for your career, for your knowledge, for your expertise, you need to learn that. I'll just close today's class by taking to you briefly on the epidemiology. If I talk about epidemiology, almost literally there is every place you find a peptic ulcer person. I'm sure in your class also, some of you are having peptic ulceration problem, isn't it? So perforated ulcer disease was in South Korea, and South Korea, they have found it to be highest annual incidences. United States, lowest annual incidences. Whereas in place like Spain, one moment. Hello? Hello? One moment. Just one minute. ಹೌದೌದು, ಒಂದೇ ನಿಮಿಷ ಇರಿ ಫೋನಲ್ಲಿ, ಒಂದೇ ನಿಮಿಷ ಇರಿ, hello? We will talk later on, okay? Let me stop here. Thank you.
Okay,
Yes,
sir.
ಹೇಳಿ ಮೇಡಮ್, ಹೇಳಿ. ಆಯ್ತು, ಕೊಡಿ. ಡಾಕ್ಟರ್ ರಾಜು ಕೊನೇರಿ ಅಂತ.